Infectious arthritis is quite often an orthopedic emergency. Now, why would you think this is? Because it's a raging infection that is restricted to a small space in a joint. Usually, it presents in a single joint that may then move to another joint, often asymmetrically. There are classic organisms that can cause septic arthritis. Most importantly, Staph aureus, Streptococcus, and Neisseria gonorrhea. The boards love gonococcal arthritis. If the patient is a teenager with migratory arthritis, a red, hot, raging joint, often pointing to the knee, think gonorrhea. How do you treat gonorrhea? Very good, ceftriaxone. What else should you be suspicious of? Well, chlamydia and other STDs. When you see the teenager and joint pain in question, your brain should automatically go to this. Flash quiz. Teenager plus sex plus joint pain equals gonorrhea and a septic joint. Seronegative spondyloarthropathies, a long term for a somewhat straightforward set of diseases. Basically, these are a group of 4 inflammatory arthritides that affect the spine and are seronegative, that is, they have negative serologies for rheumatoid factor. More commonly, these diseases affect males. What do you need to know about the seronegative spondyloarthropathies? You need to know HLA-B27, a gene that helps to encode for MHC1 molecules. This is strongly associated with these set of diseases. Again, there are 4 types of seronegative spondyloarthropathies, including psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, and reactive arthritis. A list you can remember with the memory aid, PAIR. Psoriatic arthritis is psoriasis and joint pain and stiffness. Clues on radiography are often giveaways. For example, a pencil and cup deformity, as well as dactylitis or sausage digits, are classic signs of psoriatic arthritis. These are some of those buzzword phrases that should immediately take your brain to this disease. Ankylosing spondylitis is probably the most classic of all the seronegative spondyloarthropathies. What does this X-ray of the spine look like? Well, it looks like bamboo because of the exophytic bone formation causing the vertebra to square up and stack up. It's a disease characterized primarily by chronic inflammation in the spine, classically seen in the sacroiliac joints, and then ascending up through the spine. As it ascends, it causes fusion of the spine, eventually leading to a complete loss of mobility. Additional symptoms include uveitis and aortic regurgitation, 2 important symptoms to know as they can be common and should not confuse you on the step 1. The next arthritis discussed here is one associated with IBD. There is no single differentiating symptom that you need to be aware of here, but accept that sacroiliitis that occurs in patients with pre-existing IBD is because of this seronegative spondyloarthropathy. Do you remember the 2 types of IBD from the GI chapter? That's right, Crohn's disease and ulcerative colitis. The final type of arthritis here is reactive arthritis, which used to be called Reiter's syndrome. It's known for a classic triad of conjunctivitis, urethritis, and arthritis, which can be remembered with the memory aid, can't see, can't pee, can't climb a tree. This is a great way to remember all the fully testable concepts. What will alert you to reactive arthritis? Well, probably a recent history of a GI or chlamydial infection, as these infections are what precipitate eventual reactive arthritis. Flash quiz. What MHC molecule is strongly associated with seronegative spondyloarthropathies? HLA-B27. And now we're on to lupus, the great imitator. There are a phenomenal number of ways that lupus presents, and it has the capacity to be a very different disease for many different types of patients, but don't worry, there are some consistencies, and this is what you'll be responsible for on the exam. First off, some epidemiology, which is often very important for the disease. 90% of patients are female between the ages of 14 and 45. Most of these women are African American, a population that also tends to have more severe cases. Though I won't say it's impossible, With a gender skew like this, I'll say it's very, very unlikely you'll see a male with this disease in a step 1 question. So have it in your mind when you see a young woman with something that seems autoimmune in nature. The symptoms are very varied, and unfortunately there are a lot of non-specific symptoms. These non-specific ones include fever, fatigue, weight loss. Lupus can affect every organ in the body, but you'll need to know about specific problems in the heart and kidney. So what happens in the heart? Good. Liebman-Sachs endocarditis, which you may recall from the cardio section. Here we see warty small growths likely on the mitral valve. Do they cause dysfunction? Not really. Do they embolize? Not really. Is anything growing here? No, they're just mostly fibrin and neutrophils. What else can happen to the heart in lupus? Pericarditis, the most common cardiac manifestation. Do you remember the symptoms of pericarditis? Chest pain that's relieved by leaning forward and exacerbated by lying down or taking deep breaths. Lupus nephritis comes in 2 ways. The first is nephritic, which is a diffuse proliferative glomerulonephritis. Nephrotic, on the other hand, is a membranous glomerulonephritis. Now, why did the kidneys take a hit? Well, due to immune complex deposition. Which type of hypersensitivity reaction would that be? 1, 2, 3, or 4? Very good, type 3. Now, although the symptoms and associations with lupus are pretty numerous and varied, the ones you really need to know are captured in the mnemonic rash or pain. The first symptom is rash, such as the malar rash seen here. There's arthritis, soft tissue symptoms, hematologic problems, oral and nasopharyngeal ulcers, renal disease and Raynaud's phenomenon, photosensitivity, anti-nuclear antibodies, immunosuppressants, and neurologic disorders. So what kills a patient with lupus? Well, it's likely going to be cardiac disease. It's particularly deadly in these patients, and you'll regularly get EKGs in these patients as well. If you become a rheumatologist, sometimes these patients suddenly die, and you presume it was cardiac in nature. Since they are immunosuppressed, they are prone to infections that can also be fatal. What else can immune dysregulation lead to? Malignancy. And finally, these patients can succumb to renal disease. In making the diagnosis of lupus, there are a number of serologies that are classically ordered to help confirm this diagnosis. The 4 that we'll discuss are ANA, anti-double-stranded DNA, anti-Smith antibodies, and anti-histone antibodies. ANA is probably the best known of all of these, and while it has a good sensitivity to help ensure all the cases are picked up in screening, it's not very specific for lupus, and further testing and clinical evidence is often needed. The second antibody, anti-double-stranded DNA, is a much more specific indicator and usually indicates severe disease. Do you recall from the biostats which order you want to get these 2 tests? Good. The sensitive one first, followed by the specific one. So ANA followed by double-stranded DNA. Similarly, anti-Smith antibodies are very specific for the disease. If you're questioning if a patient has lupus and you don't think you can go off the clinical evidence alone, ANA positivity usually is good to help guide your diagnosis, but double-stranded DNA and Smith antibodies really confirm your suspicion. And what about anti-histone antibodies? These antibodies are actually not related to lupus at all. They're a related disease known as drug-induced lupus. It may have similar clinical features, but drug exposure is a crucial piece of confirmatory evidence. What 3 drugs classically cause drug-induced lupus? Hydralazine, used for severe hypertension, procainamide, an antiarrhythmic, and isoniazid, an anti-TB drug. These can be remembered with the acronym hip, as in it's not hip to have lupus. Anti-cardiolipin antibodies, while associated with lupus, have another important clinical pearl. These antibodies can cause a false positive on RPR and VDRL titers. Now, why is this? RPR and VDRL have cross-reactivity with the anti-cardiolipin antibodies. What might you misdiagnose your lupus patient with? Syphilis. These antibodies also prolong the PTT. Even though labs will show a prolonged PTT, patients with these antibodies actually have an increased risk of developing a clot. What effect on the complement system might you expect in a patient with lupus? C3, C4, and CH50 are all low because of immune complex formation and deposition. Where might you biopsy to see this immune complex deposition? The kidneys, and even in the skin. The treatment of lupus is very complicated. What you need to know is treat with NSAIDs, steroids, immunosuppressants, or hydroxychloroquine. Do you recall what else hydroxychloroquine is used for? Good, malaria.